Well, our connection made in a diagnosis. And this hour, we're talking about diabetes. And according to new data, it is rising across the Finger Lakes region. More than 160,000 local residents now live with diabetes, according to a report from Common Ground Health and its partners. And like so many health problems, this is not hitting our population equally. First, some of the updated numbers, and we're going to talk a lot more about what this data says this hour. Diabetes affects more than 13% of local adults. Now, 10 years ago, 9.6% of the local population in total had diabetes. Today, it's 10.6%. That's a number that includes all people, adults and children. Most of the cases are type 2. All of those numbers are going up. Here's what they mean when they say that diabetes is not affecting our population equally. The report finds stark disparities in severe outcomes that tend to be preventable through better access to nutritious food or preventive care or early treatment. Adults in the lowest socioeconomic status zip codes are 3.1 times as likely to be hospitalized for diabetes-related conditions as those in the highest socioeconomic status areas. Hospitalization rates for Black residents are 3.1 times the rates for white residents, 2.1 times for Latino residents. So what can be done about it? Today, Connections is on the road. We are coming to you from the combined entity of Common Ground Health and Finger Lakes Performing Provider System and Rochester RHIO. They're bringing us together today to talk about this issue. Actually, we're talking for both hours on two different subjects, and we hope you'll stay with us. We have a live audience today. We'll welcome them in a moment. And I want to welcome our guests who are with us today. Jamie Hayslip is Director of Analytics for FLPPS, Common Ground Health, and Rochester RHIO. Welcome. Thanks for being with us here.
Thanks, Evan. Good to be here.
Phyllis Jackson is an RN, Community Wellness Project Manager for FLPPS, Common Ground Health, Rochester RHIO. Welcome. Nice to see you again, as always.
Thanks, Evan. It's good to be here.
And David Starks is a local resident living with diabetes who's going to tell his story. Hi, David. Thanks for being here.
So glad and privileged to be here.
Now, just a brief introduction for what Common Ground is, and that's the shorthand. I understand you all have grown over the years, Jamie, and so sometimes you're going to hear me say Common Ground Health today. It is the combined entity of Common Ground Health, Finger Lakes Performing Provider System, and Rochester RHIO, that's RHIO. That is a big set of names here. RHIO stands for the Rochester Health Information Organization. All of this works together to be, in my mind, a kind of community health think tank. You do a lot of research, data, reports that we're going to talk about, kind of as a framework for solutions. That's how I've always seen it over the years. Is that fair?
Yeah, for sure. I think, and when you talk about the combined entity, there's different capabilities from each of those organizations that are all coming together, but really to serve our community well and improving healthcare. And, you know, Common Ground Health traditionally research and data driven. We have programs that help translate that into community improvement and things like Phyllis works on, but also information that supports like policymakers and changes in how healthcare is, performed and regulated in our state, in our region. So that's kind of traditionally what we've done at Common Ground Health.
So that's where we are, and that's what we're doing today. And I want to welcome the live audience, and I would like the audience now to welcome this outstanding panel. So go ahead and do that, audience. And you will have a chance to ask questions. The audience will have some things to say this hour. Listeners and audience members on YouTube, as always, you can join the chat there. If you want to call the program, as always, the number 844-295-TALK. It's 844-295-8255. 263-WXXI if you call from Rochester, 263-9994. You can email the program, as always, the email address, connections@wxxi.org. Phyllis, let me just start with you. The headline when I see this report, which is not even officially released yet, it's coming, and you're kind enough to share this with us here for this program today. The headline to me was not just the diabetes is going up, although that is a big part of it. Mm-hmm. It's that it is going up in unequal ways. What do you see here?
I see it's going up in unequal ways. I think that our community, brown and black people in particular, and rural people tend to have higher rates of diabetes if they are living in lower socioeconomic areas. So that is the key right there.
And we're going to talk with Phyllis this hour about why that inequality exists and maybe what can be done to sort of pry things loose. I mean, Jamie, I don't suspect you do reports like this unless you believe that things can get better here. Are you optimistic that this data is going to help?
Oh, sure. Yeah, I think, we have to be data driven. We have to look at where the trends are and where the needs are and that certainly helps, bring that to the surface. Yeah.
Well, David's story is one that a lot of people can relate to. He's a local resident living with diabetes. And David, your diagnosis, you were saying before the program, was, a couple decades ago now. Is that right?
Yes.
So tell me a little bit about how that came to be. How did you end up getting diagnosed in the first place?
Well, I went in to apply for some insurance and better health plan, and they through the testing and so forth, they found out that I had a diabetic curve, and this is going back about 20-some years ago, and I was denied that insurance because of that curve that existed, and from that, my insurance agent told me, said, we got to do something. You got to do something about your health because your diabetes is growing. It's getting out of control. So from that standpoint, I began to do some things to discipline myself in terms of what I was eating. I began to do some exercises. One of the things that I found out that you got to take charge of what's going on in your own body and set yourself some goals and focus on what you need to do to get to where you should be with your health. And from there, I began to, work with my primary care doctors and do some reading and so forth and research, and now I am in much better shape.
So when you first got the diagnosis, were you surprised?
Yes, I was. I was surprised, I shouldn't have been, but I was surprised because I had just ate a couple of slices of pizza. And it's something you don't do, and you go in to have a health examination for some insurance.
You ate the pizza on the day of your health examination?
I ate it a day before, and that's still in your system. It's still there. So that's where the curve started. And then from that point on, I had to take charge and get some things under control.
So we'll talk about diet in a moment, but take me back a little bit with your own family history. My understanding is that there was diabetes in your family. Is that right?
Yes, diabetes is very strong in my family on my mother's side. She had some serious problems with diabetes, and also it's hereditary. And my sisters, I have several sisters, and they're all diabetic. The whole line is all diabetic.
And so how serious was it for your mother?
For my mother, it was quite serious. It led to some stroke situations, and she didn't die of it, but it contributed a lot to her health.
And so did you know that when you were growing up? Were you aware that her diabetes diagnosis was related to that?
I really didn't notice, raised on a farm like I was in Forest City, Arkansas. My father was a farmer, and we ate everything, when it come down to, your eating habits, and it has a lot to do with it, bacon and sausage, and raised on a farm, you eat, a lot of carbohydrate type foods and, rice and beans and all of that, and being so energetic, you don't tend to think about that, you're burning it, you're working on a farm, and, but later on it catches up with you.
Is there something cruel about the fact that the most delicious foods are always on the list that we have to give up?
That is very cruel. That is very cruel.
What were you worried about giving up when you got the diagnosis?
Well, giving up, soda and giving up, potato pies. And, you can eat this stuff, but you got to do it with portions and discipline.
Mm-hmm. How much soda did you used to drink?
Oh, my. I would say too much, or a couple or liters,
A couple of liters a year.
Well,
a month.
A month.
A week. So you miss it. But, on a more serious note, you talk about your siblings as well. So before your own diagnosis, did you know that your siblings and that you had this family history, or did you only kind of start to really grasp that after your diagnosis?
After the diagnosis.
Okay. Do you think it would have changed anything for you had you known?
Yes, it would have. I would have been a lot more cautious and thinking about what I was taking into my body in terms of sugar and sweets and so forth. Sweets was my thing. I just love sweets. And didn't think about what it was actually taking place in my body, the storing of the sugar and so forth over the years that took place.
we'll talk with our other guests about this coming up here, but certainly when we've talked about diabetes on Connections over the years, we've had people living with diabetes like yourself tell us that there was some reluctance to even get a diagnosis, that the idea was, what do I have to give up? What do I have to change? Is it worth the trade-off? How quickly did you embrace the need to change? Did you sort of resist it at all?
Yes, there was some resistance. I, didn't really take it serious. And then there were people that I knew, friends, that actually got so bad until they had to, amputations had to take place. I lost a friend, that had to have their legs actually amputated. And I began to recognize this is serious stuff. And I had a good primary care doctor that talked with me, and he would go over things like, you don't want this disease to get out of control. And what could happen, blindness, and all of these things. And I really took it serious. I started looking at that, and I said, I don't want that to happen to me. I began to take charge and do things to, to make my health better. And I didn't want a lifestyle that led to that kind of a condition, So I began to make the adjustments.
How do you feel these days?
I feel excellent this day. I had a visit with my primary care doctor about a month ago, and he was so excited. My A1C had dropped down to 6, and I was running like, 9s and 10s and so forth. And he worked with me on it, and he encouraged me, keep doing what you're doing. You're on the right path. And that was, that motivated me to be a lot more disciplined and careful with what I eat.
Now, you talked about, understanding that there are certain things that you maybe shouldn't eat, or at least eat less of. Do you drink any soda these days?
Very little.
Very little?
Very little.
Okay. And do you miss it, or are you kind of good with it by now?
Well, I'm pretty good with it now.
Okay.
I missed it at the beginning, but, I'm at the stage now where I can have it or not have it.
And what is a comfort food? What is sort of a little cheat where you say, okay, I can have a small portion of this. It's not going to be the end of the world. I'm not going to do this every day.
Well, potato pie.
Potato.
Yeah.
Whose recipe is that?
That's my son-in-law.
All right.
And my wife.
It's pretty good?
Yeah.
Okay. Well, look, you look great. I'm glad you're doing well. And we'll get more of David's story coming up here. I wonder, Phyllis, you've done a lot of work with a lot of different people over the years, and I wonder how common this kind of story is that you hear.
It's very common, but the outcomes are not as common.
Mm-hmm.
So we love hearing these kind of stories. These are the stories that we want. And the barriers that are in place are the ones that we know about: where you live at, what zip code you live at, the availability of fresh food. We live in food deserts, food, those kind of things. But I think that in addition to all of those things, there are some more important things that I think David had that we're not providing our community with now.
What's an example?
An example is he had family members. Number one, he had a primary care physician, Keith, that talked with him, spent time with him, went over that. We have a great mistrust in our community of medical systems anyway, and that has proven to be true because we look at health disparities and health inequities. All right, so we don't have trust. The relationship with our primary care physicians has changed. We used to could have those conversations, go in the office. We don't have that anymore. We get maybe 10 minutes, so you got to go in prepared, bam, bam, thank you, ma'am, and you're out the door. And so I think that the mistrust of the medical system has moved over to our primary care physicians because they don't have time to get to know us and spend that time. The other thing is that we say, we as people, I think that risk does not mean it's gonna happen. It does, the risk, it's a risk, but not necessarily.
It's not guaranteed.
Exactly.
Yeah.
And the other thing is culture. I think one of the things that we never think about when we're talking to people is how will this affect how you think about the culture and the food that you grew up with. So I know there's resistance. If my mother has always cooked with ham hock, smoked pigtails, and all of that in that taste, and save that fat in the jar, put it in there to give it some seasoning and some salt and all of that stuff. And you tell me that I gotta, you got diabetes and you're putting yourself at a risk for diabetes and you really need to change your diet. Well, good for you, but my mother would turn over in her grave if I changed the way I did, and I don't want to be disloyal to my culture, to my mother, to my culture. So that is a resistance factor that we don't often talk about. We don't even think about it.
So then it becomes, this is not just a medical conversation.
Exactly.
This is not just a straightforward, here's your risk factors, here's your A1C, here's everything that's going on now. This is a question of, can you make the changes, and can I, as the provider, understand why you would be resistant?
Exactly.
So how much cultural competence do you see, or does the system lack some of that?
Well, I think, we have all kind of classes, and every medical professional in the world has to go take a class on cultural competence. Being cultural competent does not mean that you're culturally humble, that you're willing to listen, to ask questions. We just go through it because we got to go through it. But we, day-to-day life is really not like that. So I think that we have a lot of that's lacking. And the other thing that's lacking is health literacy. And I know that's my bandwagon, but health literacy. But understand this, too. Health literacy is 12% of people are not literate, whether educational level, where they live or whatever. But health literacy is giving people information, in fact, and giving them the opportunity and the power to ask the right questions and then to do what he did, which was take charge and manage his health care. Now, health literacy by itself can spur activation, but it does not necessarily mean that people know how to apply the information in a way that's comfortable, in a way that is passionate, in a way that will drive them to move it forward. And so we miss that part. We don't have how do we eat an elephant? We're telling them to eat an elephant and say, how do you eat an elephant? Well, I don't eat elephants. You know what I'm saying? No, one bite at a time. And so we don't teach, how do we do that one bite at a time? The medical system fails us. Those that are in these communities fail. Well, food deserts. We know that there are food deserts. There's not a lot of food, but listen, we got stores that people go to the market and all of that. Number one, you want me to eat food that I'm not familiar with. Nobody's educated me really about that food, how it tastes, what's the difference, and all of that. Number two, you got corner stores, and they're selling stuff in there. It's fast food, it's quick, and my ramen noodle story. I love ramen noodles. I'm never going to give up ramen noodles. Okay, 4 people in communities, college, eat ramen noodles. It's not good. It's full of salt and all of that stuff. Did you know there's a way to make a healthy meal out of ramen noodles? But we don't teach that. We don't dig deep enough to give people the information or the how-to make do. I grew up making do with what we had. We don't teach that anymore. So there are some things that we can adjust within our medical system, with our providers, but also within our community.
So in a moment, I'm going to ask Jamie to kind of take us through more of the data, which I think we should really try to understand. And it will underscore so much of what Phyllis is talking about. This is not meant to be a political observation. I just want to give you an observation of something that I heard in the last week in national politics that relates a little bit of what you're talking about, is the disconnect. So in a prepared speech, the president was talking about health. And in his speech, which he appeared to me to be cold reading for the first time, he mentioned corner stores. I don't know if you saw the by where he actually paused and said, what is a corner store? What are these things? I've never heard of a corner store. To the president, this was like a brand new concept. And I only bring this up because, not to pick on the president, not to make it political, but to say that if people in power and powerful positions are not just politics, they're people with wealth or community prominent positions, doctors, if they have a patient and they say, well, look, you shop where? Stop shopping there. Or your family makes what? Well, stop eating that. It seems obvious to someone disconnected. The actual practice of changing it is not nearly as easy. And what concerns me most is when you say, sure, there's cultural competence training. You don't seem to think it works very well.
Look at the numbers. It's really not working that well. And not just with diabetes, but with other conditions as well. Number one, there's not time. You got 10 minutes. You got time to be culturally competent. So I have diabetes. I have a physician, primary care physician, that left the system, and now she has concierge medicine. We have time together. We talk, we share, whatever. She calls me to check on me. And one of the things that they have is a program where the doctor goes out every Saturday with that group, and they have a walking group with their patients. You know what I mean? And they have groups at their office for people to come in, support and all that. Now, that's concierge, but that could be done other places. But we don't think beyond, this is what you need to do, and this is how, we give people mandates without giving them the way and how and why do we do this. They don't really understand why, and it's not important because I got other things that matter more. So we also have to motivate them. What are you passionate about in your life right now? Do you have grandchildren? Do you have children? Do you want to aspire to something different? Do you want to be out in the community? Do you want to work in your church? Do you want to not, do you want to not go blind? You know what I mean? We have to give them something. Why do you want to live? Why do you want to get this control? Why is it possible? Why do you need to do this? And then we need to engage where people live, where people work, where people pray, and where they play. And when we engage them with understanding and with support and saying, listen, there is a quick fix out there. And, GLP-1s are out there now. The doctor's very quick to say, let's get it now. Everybody wants to take GLPs, because it's a quick fix. There is no quick fix ultimately, because even if you take the GLP-1s and lose your weight and all that, you still get off of those. If you have not made a change here and here, you're going to go back to the same habits. And so what we have to do is help people make a mind shift, but that takes time, and it takes investment of funds for people to be, no matter where they live. It takes time and investment. I did not want to change my diet when I was told I had diabetes. I hated that. I felt that I needed to, that's the way I've always cooked. It's not going to taste the same. All right, but I had to try and experiment. And one of the things that I did was I went to Tops at the time cooking class. And they fixed some food that I thought, nope, not going to like it. I had my mind made up, and it was good. I'm just saying. And so that kind of flipped my mind. And so we can do things in our community with what we have. I think that we always want to shove people into doing the Mediterranean diet and all of these things. And I'm not saying they're good, and I know they're good. There's good diets. But listen, you just can't throw people in there and say, do it. You've got to be able to work. What do you eat normally? How's this going? Yeah. Are there any work? We should have cooking classes at every church, at every rec center, and have those things playing in doctors' offices. We should have those consistently all the time. Exercise, well, they say the community can't go out and exercise. It's not safe in these communities. And then I see they're working on, shout out to Healthy Kids, parks and things that building up where kids can go out and play. Well, I live near Greece, not quite, but near Gates. They kicked us out and we're a city now. But there's a park. And they have stuff for kids. And you know what they find? I used to walk. I hate walking. I hate exercise, period. Let's not lie. But I will do it, limit. And they had these things where you do your arms, and they had the swings where you walk on them in the park for adults. I was like, get out of here. And I found that when I would take my dog for a walk, I would get up and do those because they're right there in the park. The kids take my grandkids to the park. They're playing, and I'm over there. It's kind of fun because you're doing it outside, and it doesn't feel like exercise. You know what I'm saying? So that could be in every park. That should be in every park. But that's not the way that we're thinking. That's not the way that we're taught to think. Tell them what to do. They do it. People are resistant to being told what to do.
Especially if it goes against culture and identity.
Absolutely.
Yeah. David, what convinced you to change now? Once you got the diagnosis, you said there was a little bit of resistance. What got you on board eventually?
Well, one of the things that I had to think about is the fact that when I was growing up, family came together and we ate all at the same time. And that's one of the things I see now that cause problems that I see is that when we sit down at the table, everybody eat what they want to eat. In most cases, even our children, they will say that they don't even want what's at the table. And the accessibility of all kinds of foods, availability of it, it makes it easy for us to get off track and just start eating whatever is there. But we had no choice. We had to sit together, and the meal was made, whatever it was. If it was beans and rice and greens and all that stuff, the balanced meal, we sat together, we ate. But now I have noticed, and I found myself doing that, you get off track when, you start grabbing stuff that's not good for you. It's there, and you're hungry, you're craving, so you grab potato chips and I start looking at that. I says, I got this, start allowing these kinds of temptations overwhelm me. And I began to resist it and going to the healthy, looking at the healthy sides of the foods. And one of the other things, that my wife taught me, she says, read the labels. Mm-hmm. And most of the time, we don't take time to read what you're eating. See how many calories and see what you're putting in your body. And I started doing that. I started looking at that, and I said, this makes sense. I began to cut back and eat less of this, and not eat it at all. So that kind of got my attention.
Well, let's talk a little bit about the data here. Jamie Hayslip is Director of Analytics for FLPPS, Common Ground Health in Rochester, RHIO. And the data is part of why we're here. This report that's coming out from your organization paints this picture. This would be an important story even if the numbers were going down. But the numbers are not going down. Why don't you walk us through first where the numbers are rising and what we're seeing, and then we're going to talk about the actual cost of that. Can you go through that?
Yeah, sure. So the data we look at that referenced in this study that's going to come out soon, we look at the whole Finger Lakes region, so a 14-county span in this area. And the latest numbers are there's about 160,000 people diagnosed with diabetes now. That represents about 10.6% of the population. We have seen a slow but steady rise over the past about 10 years, from about 9.6% to from like 2016 to where it is now about 10.6%, and it's slowly, you can see it creeping up. So left unchecked, we anticipate another 25,000 people by 2032 will also be diagnosed with diabetes. So it's definitely going up, slowly and steadily. And
to the point about the sort of unequal effect here by zip code and socioeconomic economic status, what do we know?
Yeah. So in terms of just prevalence of diabetes, one statistic is adults over the age of 35 in our region are in the lowest socioeconomic status zip codes are about 72% more likely to have diabetes than the highest zip codes. So that even translates, that's just prevalence, but that translates into some disparities we see in outcomes. So people that are hospitalized, so for example, those lowest SES zip codes, they're about 3 times more likely to be hospitalized than in the higher zip codes. And even in other demographic breakdowns, like race, ethnicity is an example. So compare like black segments of our population, they're about 3 times more likely to be hospitalized than white.
About 3 times more.
3 times
it's
more.
A huge number, yeah.
And Latino segment is about 2 times more than the white population. So it's quite stark disparities there.
And this is, you hate to sort of boil this down to dollars and cents and numbers, but I mean, that's part of the story. This is a huge expense on communities, on individuals, on families, on health systems. Tell me a little bit about that.
Yeah, so we've taken some national numbers on expense for healthcare and other dimensions of it and applied it to our region. And we estimate it's about a $2.5 billion expense altogether. 600 or more million of that is due to things like lost productivity in the workforce. One interesting thing about diabetes is that generally speaking, it affects people, in older age groups. The older you get, there's more prevalence. Mm-hmm. But the average age of a hospitalization for someone in a region is 53 years old. So that's prime working and caregiving years. So that really tells us that it's, that those folks, it's affecting not only economically the healthcare, expenditures, it's affecting workforce and it's affecting families.
Are there solutions that stand out as clear, obvious, attainable here?
I think there are some for sure. And I think generally speaking, we're talking about type 2 diabetes in this conversation, which is something that usually comes on later in life and is affected by things like diet, exercise, stress, but can be addressed. And the earlier you address it, the better. So one piece of data is 8 out of 10 people with pre-diabetes don't know they have it. They're undiagnosed. So early detection is very important. So if you understand that earlier, you can do something about it. You can change your diet, you can exercise, you can help fight it off, so to speak.
Okay, and most of the diabetes in our region is type 2. Is that right?
By far, yes. Above 95% of the prevalence is type 2 diabetes.
So that means, Phyllis, some of the solutions you talked about and maybe some sort of coordinated community response, this is not a problem that is not either solvable, or at least this is not a problem that can't be lessened with effort, right?
Absolutely. Absolutely. We talk about the numbers and how much it costs. If we invested some of that money up front, then we wouldn't have to spend all that money on the bottom. Because if you prevent it, then you don't have to worry about the downstream amputations and all of those things, which are costing a whole lot more. The fact of the matter that you get these people right in the middle. Number one, they talk about pre-diabetes. I absolutely hate the word pre-anything. It's like telling somebody you're a little bit pregnant. There is no such thing. And this is how generally people in the public hear that. They hear pre-diabetes, and that means what? I don't have to do anything. I haven't got it yet. You know what I'm saying? It's not gonna, I'm good. You know what I mean? And so that goes by the wayside. So we need to do some work around language and being really straightforward and engaging people about what that really means. And then the other thing is that, again, it comes, I think, to a lot of cultural and people in lower social economic status. I grew up poor. And so, not poverty-stricken, but poor. And so, but in our culture, we didn't go, my dad, I don't know my dad ever went to the doctor unless we made him. You know what I mean? And, but the other thing was, before we went to the doctor, we tried every home remedy in the world. We got all kind of recipes to fix stuff. And so we always tried that before we went. Mm-hmm. So we've got that part. The other thing is, number one, I can't take time off to go to the doctor. I mean, they give me appointments, but I can't make it, and I don't have no way to get there. And then when I get there, the doctor don't give me time anyway. So, I mean, I just don't take the time. Who's going to take care of my kid? I got other things that are in my mind that I need to take care of that seem more important, especially if I'm pre, because I'll take care of that later. You know what I mean?
Yeah, at least I don't have diabetes. I'm only pre-diabetic.
Exactly. And so it doesn't set in that I need to really do anything. I'll just take care of myself.
No, I mean, the point that you make about systemic trust is really, really key here. And it's hard enough, as you say, to get most men to go. Is there something fundamentally wrong with men to not go to?
Yeah, they're men. That's fundamentally wrong with men. They're men.
We have to take our only break of the hour here. You're hearing Phyllis Jackson, Jamie Hayslip from FLPPS Common Ground Health, Rochester, RHIO. David Starks telling his story as a local resident living with diabetes. This report that's coming from Common Ground Health tells the story of diabetes in our region, and it's a troubling picture in some ways. In many ways it is. The numbers are going up. The numbers are not going up equally, but we're also talking about solutions, and we will come right back with some feedback and questions for our panel next.
Support for your public radio station comes from our members and from Mary Cariola Center, supporting residents to become active members of the community, from developing life skills to gaining independence. Mary Cariola Center, transforming lives of people with disabilities. More online at marycariola.org. And Monroe County Economic Development, accepting applications for the Micro Advantage designed to help small businesses with expenses such as equipment.
5, 4, 3, 2.
Business.org.
This is Connections. I'm Evan Dawson. We are on the road today, coming to you from the combined entity of Common Ground Health, Finger Lakes Performing Provider System, and Rochester, RHIO. Sometimes you'll hear me refer to it as Common Ground Health, and they have been working on a report on diabetes, among many other projects, of course. And so this hour, we're talking diabetes. Next hour, a different subject. Both hours here live with a live audience. We're glad to have them here. I will tell the live audience in the room, if you've got questions, comments on diabetes, David's got a microphone in the back here, I think. Is that right? And we can take your comments, questions coming up here. I'm going to start with an email from a listener named Dallas, who is asking about food stamps and SNAP, and wants to know if part of the solution essentially is to limit SNAP to more narrow foods, healthier foods. Phyllis, what do you make of that proposal?
Well, I feel that's a good proposal. I've always felt that it was too liberal in what people were allowed to purchase with SNAP benefits. But the problem is you can limit what they can purchase, but they're going to get it anyway unless they know and have a reason not to get it. So, I look in carts, and you know what you find in the carts when they're trying to limit the sweets and all of the sugar. But I find fast food, I find SpaghettiOs and all of the stuff that, fast food, microwave, and quick, and it's full of all kinds of everything. Number one, you say read labels, and that's a great thing. So we tell people read labels, but do we actually know if it says carbohydrates, fats, they don't know actually what that means. So it doesn't have much meaning. Kids don't read labels. They don't know. So one of the pieces that's missing is early education. They want sweets. They want what tastes good and all of that. And so, but I think that it's a good step toward it if you add the education piece into it of why, we're limiting these kind of things and then help them begin to learn how to embrace that. Why? Maybe not for you, but for your kids. This is what happens.
To some extent, Phyllis, the debate about SNAP and what it can purchase has become either politicized or controversial.
Yes.
Why do you think it has been?
Because, people don't want to be told, again, nobody, I don't, you don't, nobody wants to be mandated. If you're going to give me something, give it to me. Why should you be able to tell me what I can buy and what I can eat? It's just human nature, and we don't like change. Nobody likes change. So when change comes and we're not a part of it, especially if it's coming from a source that we don't particularly care for, not being political, but just coming down from a source that doesn't know anything about me, they don't care about me. This is something that's saving money, and it always comes down to this. Oh, they're just trying to save money, and they're doing it on the backs of us because we're poor or because we need this. And so it's all, again, about the thinking of how it's presented, and then when you present it, what do you give to go along that enables people to be able to say, yeah, I can work with this.
Okay. On the policy side, you want to jump in there? Yeah.
Just a comment about SNAPs and maybe a little bit of a different view of it. We recently looked at some data from the 211 Lifeline call data and noticed an really interesting kind of increase in call volume related to food and nutrition concerns. And specifically in late 2025, the rate of those calls doubled compared to the year before. And I think that coincides, a lot with the federal nutrition assistance changes and insecurities around that. So that's something that definitely has an effect on people trying to manage their health through nutrition.
All right, it's 844-295-TALK throughout these 2 hours. If you want to call the program, 844-295-TALK. The email address is connections@wxxi.org. Maureen writes in to say, Evan, no doubt the president was born with a silver spoon, well, actually a gold spoon in his mouth. He has likely never been in any large grocery store, except maybe during a campaign stop, let alone a corner store. That reminded me of when George H.W. Bush was at a campaign event in a grocery store in 1992 when he saw the scanner at checkout. He said something like, how long have those been around? As you noted, wealthy politicians such as, I'm just reading Maureen's email, everyone. I'm not endorsing anything. She says, as you noted, wealthy politicians such as Bush 1 and 2 are often devoid of cultural awareness or responsiveness of everyday people. I mean, again, this is not me trying to play both sides. I think in general, political leaders, they are wealthier than the average. Of course, some have come from poorer backgrounds, but on average, the Congress, the Senate, the presidency skews wealthier. And that skews, as you said earlier, Phyllis, a little more detached from the reality of what people who are struggling to make ends meet, what they are going through. Mm-hmm. Fair enough? Yep. Okay. So, Maureen, I appreciate that point. I don't remember. Somebody can fact check me on that incident in 1992 with Bush if it actually happened. We try to fact check in real time here. But to the point about corner stores, do you think corner stores, how important of a role can they play? And policy-wise, is there anything to do there, Phyllis?
Don't start me on corner stores. I think you walk around in the zip codes you're talking about, in every other corner or every corner there's a corner store. All right. So they're multiplying. They're going to be there. Doesn't look like they're going away because we can't get policy changes to kind of regulate what they do and whatever. So there was an initiative at Common Ground Health where they were working with corner stores to be able to help them, bring in some healthy foods and, live food. Yeah. Okay.
Fresh food.
Fresh food. Okay.
Yeah.
And
live food, sure. Food.
Well, it's alive because it has chemicals and it causes anyway, and so we were doing that, and some of the corner stores have done that. So, my thinking around corner stores is they're going to be they're a bane of society, but not a bane of society because people in poor neighborhoods that can't get any place else need
Especially
that.
if there's no grocery store within miles, right?
Absolutely. So if that work that was begun on helping corner stores, so if they're going to be there, then we need to put some regulation on it, some restrictions on it, some boundaries on it. And that's something that we should be working at. And said, if you're going to be here, these are some requirements for corner stores. You got to have fresh food in there. You've got to be able to operate. Now, the problem is they tried that for a while. And what happened was people weren't buying the fresh stuff, because we're so accustomed to buying the fast food and so accustomed to making it quick. And younger people tend to shop at corner stores, younger families with kids. And you know what? They don't know how to cook fresh food. They don't know what to do with the collard green. They don't know what to do with squash. They don't know if they have listen, McDonald's does not sell squash unless it's fried. Okay, so they don't know what to do with and the stores are saying losing money because they're losing, the food's going bad because nobody's buying it. So if they're there, what can we do legislatively to make sure that if that's what we got, and how can we utilize them and make them into a resource in our community? And that is going to take the work of the city, of the county, of all of these organizations coming together and say, listen, we've got to support the people. They're not in it just because they want to be philanthropic. Oh, I want to help our kids. No, they're in it to make money. So how can we support them in making money, but also being an asset in our community?
Well, maybe related to that, here's an email from Jackie. She says, I wonder if part of the issue is that when we hear about hunger in the community, we do food drives focused on calories rather than nutrition. She says food pantries are giving out breads, cookies, ramen noodles that are cheap to buy or easily donated, but maybe not as good for people's health. Maybe organizations that are there to help with food could be helping more with nutrition.
Absolutely.
You agree with that?
Yes, I do. I mean, we have pantries, and everyone I've been to, they get what they're given. Whatever people donate is what they get. People are hungry; they just want to eat. And most of the time, in poor communities, our diets are really loaded with carbohydrates because they're filling. They make you feel full, and beans, rice, potatoes. Those are things that are given. Canned food is easy. If you're working and you're a working mom and you've got kids and you work late and you got to take the bus, I'll take home health aid. They've got to have. They've got 8-hour case. To get 8 hours, they got to work at least 10 to 12 hours if they're taking the bus. All right, so you get home and you don't have time. You think, I can't cook. The kids are hungry. They're screaming. You got to go pick them up, all of that. You want something quick. And, so you pull out the potatoes. Listen, I eat rice with every meal. Do not feed me without rice, okay? But we pull out the things that make them feel full.
And who can blame people in that
I know,
scenario?
absolutely.
Right.
What do you expect them to do with that?
Anything you want to add to those points there, Jamie?
Just another aspect about food and maybe some of the supports and what we can do about it. We've been doing some work with New York State in the Medicaid reform space, specifically what's called the 1115 waiver. And that does have some provision for things like, food as prescription or food vouchers for prescription, which I think is great. Also, I just learned not too long ago that it even extends to things like cooking supplies or equipment. So like microwave ovens or refrigerators that people might need that, are essentials to, keeping food or cooking food. So that's another area, supporting those system level changes like the Medicaid reform work.
What's that look for,
Well,
Phyllis?
I applaud these changes. I applaud them doing all that and providing all that. But, I got an air fryer. It's been sitting in my house for 2 years. Never used. You know what I'm saying? So it's wonderful that these things are available and they're providing them. But if you don't give people some application, how to use it, why it's important, it can make it easy, it doesn't happen. We have to, just providing things does not make, people are not going to use them just because you provide them. It's nice to have, but if you don't know how that really significantly can improve and change your life, listen, and make it easier, because we're trying to make it easier in the times that we live, then it really does not accomplish much. And I think that's what we throw these things, solutions, and it sounds good to those that do it because well, we're trying to help. But are you really asking people what really helps? You know what I'm saying? And I can have a microwave. Everybody and their mama and their grandmama, great grandma, and even the dead folks got microwaves. I think they got microwaves in heaven and hell. But, doesn't mean that they know how to use them in a way that they really can prepare some healthy food in microwaves. You know what I mean? So we're not educating, we're not training people how to use the tools that are available. And that is key. And we wait too late. We wait too late. We should be doing this in grade school. We should start off our children. We should be having food challenges in grade school and teaching kids. We should have home ec in our schools where people learn how to cook again with the way that people cook now. I mean, there are so many things that we could do that are probably much less expensive than providing all of these equipment, when we could just go back and, do home ec and have these classes and teach kids how to chop up food and cook it.
Well, David, how much more well-rounded is your food knowledge than pre-diabetes, or I'm sorry, not pre-diabetes, your diagnosis of diabetes? I didn't want to get caught there. Before your diabetic diagnosis and now, how much more well-rounded is your food knowledge?
It's great. Matter of fact, my knowledge about, the food and types of foods and, what you're putting in your body have grown tremendously, because I began to focus on that and talking with people that know about it. It's one of the things that we don't do. We don't share enough about, the food that you're eating. And that has been a great help to me and seeking the knowledge. I began to, seek it out and study it more and talk to people that, are dietitians and so forth that can help you understand, how to eat. Some of the things, it's not always the food is bad, it's the portions. Cut down, don't eat so much of this, And my doctor, primary care doctor, told me, he says, it's all right to eat a little sweets here and there. He said, but you portion it, you don't eat too much of it. And sometimes you sit down and eat a whole potato pie, or drink a whole thing of orange drink, and craving for it and just keep going on and on. This is how you get out of control. And next thing you know, you have a level of sugar that built up in your body, and that can be very damaging.
David, as a thank you to the audience, you're all getting his potato pie recipe.
His wife and his son.
This family loves potato pie. But I take the point. I mean, sometimes it's easy to let it get away from you and going, how much did I eat here? Yeah. Why did I, as opposed to, hey, I had a craving, but I don't know if I needed the size there. That's right. A couple other comments real quick before we lose the hour. Kathy here in the audience wanted to know, just briefly, distinguishing type 1 and type 2 diabetes. Phyllis, you want to hit that?
Type 1 diabetes usually it used to be known as juvenile diabetes because children are born with it. It's where the pancreas, the organ that produces insulin that controls sugar, is not producing insulin at all. And so the body is not getting it. Type 2 diabetes used to be called adult onset diabetes because it usually only happened in older people. And that is that the pancreas is producing some insulin, but it's not enough, or it's producing insulin, but it's not making the connection and being used properly by the body. And it tends to, they generally do produce some, but it's not effective with the system.
Okay, and again, to Kathy and everyone listening, type 2 more common, and of course, both are issues, but in our region, type 2 vastly more common. We got one question in the audience. Got to keep it tight here, David. We're running out of time. Go ahead, sir.
Yes, thank you. I was wondering if someone is pre-diabetic, I know we're not supposed to use that term anymore, are they able to move away from it and not be diabetic at all? And what's the data around the people that are diagnosed that are able to no longer be classified as diabetic?
So, in other words, can you avoid? Can you avoid actually becoming diabetic if you get the diagnosis?
Yes.
Phyllis,
Yes.
the answer is yes.
Yes, you can. Absolutely can. It's a risk factor in getting full-blown diabetes, but if you do the things that you need to do, and that includes the diet and the movement and the changing of thinking and all of those kind of things, you absolutely can prevent from moving into full-blown diabetes.
Can you get a reversal of a diabetes diagnosis?
Yes. People
Even
that
that,
have
yeah.
type 2 diabetes and have lived with it for a long time, making the changes that is necessary, okay, have actually gone back and gotten off medication. It is very possible to do that, but there have to be changes.
So the music is playing, which means this hour has flown by, and I'm going to ask the audience to thank this wonderful panel for the conversation here. Thank you very much. Hey, Phyllis Jackson, thank you. Great to see you. David Starks, good luck to you. Thank you very much. Jamie Hayslip from FLPPS Common Ground Health, Rochester, RHIO, thank you for detailing the report that we will be looking for that's forthcoming. We appreciate your insight here. We are live on the road today with the combined entity of Common Ground Health, Finger Lakes Performing Provider System, Rochester, RHIO, with a live audience and more connections coming up.